So I guess just off the top, I'll just point out, as Kayla was describing what her family had experienced, there were certain things that she glossed over, but that are really important for the physicians. And the most important thing is listening to the patient, particularly a parent. And I'm sure Kayla had, as she said, expressed concern several times, and for whatever reason that wasn't followed up on. The other thing that is to be learned about it is that, at least with sarcomas, which are very bad cancers, the ones that are in the soft tissues, there's ones that are in bone and ones that are in soft tissues. Jocelyn's was in soft tissue. That doesn't hurt. So in an adult or a child, they have these malignant cancers that can become, the size of a basketball in an adult, that they don't cause any pain. So that could be very misleading. The other thing about Jocelyn's story is when something is growing, that needs to be explained. So I was just sitting thinking, I know most about orthopedics, well, a lot about sarcomas, but in their lifetime, an orthopedic surgeon, if you fill target field, how many of you have been to target field? If you fill target field with people, that's the number of new patients an orthopedic surgeon will see in their lifetime. And someone in primary care, someone in pediatrics would see like 4 target fields full of patients. But an orthopedic surgeon, who is a person who sees extremity problems, lumps, bumps, bone pain, in target field there would be 1 patient on average that would have a sarcoma that they would see. And so the point is that the awareness of the possibility that a person does have cancer, even though you're in a non-cancer field, needs to be appreciated. And the other is the old expression, you don't know what you don't know. So just because you don't know what's going on doesn't mean someone else doesn't know what's going on. And when you have a mother or any patient telling you over and over something's wrong that you haven't explained, you don't know what you don't know, because you don't know what to do, because they have the same complaint and you still haven't figured it out. So have someone else take a look at the situation and see if they can help you. We do that with the sarcomas all the time, and we see that's all I do. But even when you know what they have, it's good to get help and get input from your peers. So really what I'm talking about is evaluating bumps mainly, and then pain. And so when I see a patient in my clinic that's new, particularly a child, I can usually tell just by talking to them if they have cancer or not. And when I was in your guys' situation, just to let you understand how change occurs, there was no electronic, I'm 58 years old, there was no electronic medical record. It was big, huge paper charts. There was no digitized imaging. We would carry these big baskets of x-rays around. MRI did not exist. And so phones were attached to the walls, and when you took call, you had to go find a landline to answer. So there's been tremendous change, obviously, since then. But what hasn't changed is the core need to listen to patients, understand their symptoms, and really have them tell you their story. Now that's difficult because there are mounting pressures on you to see patients faster, have someone who you're supervising see a patient who is a healthcare professional but doesn't have the training that you do. So the thing to practice and learn is how to identify the patient very quickly who you have to spend more time with. And you've seen a great example of that today. The other thing to learn about interacting with the patients is to understand what their symptoms actually are. So 1 of 9 patients roughly that goes to see a doctor today in the United States has a musculoskeletal complaint. 1 in 9. So I mean, that's millions of people today. So how do you differentiate that person who has like a cancer in their arm or leg from the one who doesn't? And while it's not perfect, the core principles are listening to them, examining them, and understanding basic things about pain and tumors that can help you say, you know, this patient is different and I need to do something different for this patient, whether it's have someone else examine them, whether it's order a scan, whatever. So what I'm mainly want to emphasize, I already did emphasize, but I'll go through a few slides. And then I think one other message is that, you know, taking care of cancer patients is really an awesome job. It's a huge responsibility, but it's very rewarding. And all of you guys should think about doing that. And if you answer yes to that question, you should then think about taking care of sarcoma patients. You can do it as a surgeon, which is like the biggest, best surgeries ever. And I'll show you some pictures of those. You could do it in radiation therapy like Dr. Dusenberry, who's just a wonderful role model and mentor. You could do it as a chemotherapy doctor, either with children or with adults. And one of the really fun things about sarcoma, or the rewarding things, is you take care of patients of all ages. So you take care of patients like Jocelyn, but you also take care of, you know, an 82-year-old who has a new diagnosed sarcoma. It's also very challenging because you do it all over the body. You know, like orthopedic surgeons, some of them, you know, they operate like from the wrist down. But if you're a sarcoma surgeon, you operate everywhere. Pelvis, neck, back, shoulders, hip, you name it, they call you to take it out. Okay, so think about that, because it's extremely rewarding, and we need really good doctors to go into cancer, and we need them to go into the treatment of sarcomas. All right, those are my main messages. So now we'll do some slides. So this is a really interesting set of pictures. So for those who are not orthopedic surgeons, that's an elbow. And then on the other is the, let's see, that's the thigh. And so the point of this slide is the sarcoma could be either one of those. You know, this would obviously, you know, you wouldn't miss this in an exam room unless you didn't, you know, undress the patient or you just didn't listen to them. This is probably a malignant tumor. It might not be a malignant tumor. You know, it might be a hemophilia patient who got in a car accident and had a big bleed into their thigh. This little bump up here is a bump on the elbow that is a sarcoma. So, you know, it's about the size of a gumdrop, and that can take a person's life, whereas, you know, this is probably a sarcoma, but it could be something else as well. So size doesn't necessarily predict how seriously you should take a bump. So just to give a little teaching about what are the important parts of seeing a patient who presents to you with a bump. So as Dr. Dusenberry said, I've seen hundreds of poorly managed sarcomas. Probably 1 in every 3 I have to figure out how to unscrew something up. And the physicians are trying to do a good job. They want to help the patients just like you guys do. But I think the most consistent problem is they don't think through the differential diagnosis. Like, it's not a bump, okay? That's not a diagnosis. That's like a sign or a symptom or something. But could this mass be cancer? That's the point. When the physician asks themselves, could this mass be cancer? And they answer yes, they do the right thing. You know, they want to do the right thing, but that moment they just miss it. They don't think, like, what could this be? You know, they got to get into the next room, or they're late, or they're, you know, I don't know what, lots of things. But so what is a differential diagnosis? And then when you listen to the history, which we heard such a clear history from Kayla, like, does it make sense? So here's the thing, you don't know everything, okay? When something doesn't make sense, you're really smart, okay? If it doesn't make sense to you, then you have to have someone help you figure it out. Just like they're going to have you figure stuff out. But you have to follow your intuition if things aren't exactly clear. So that's what I think is the biggest challenge. Is in a busy office, you're seeing 30 patients a day, and you come across a bump. It doesn't hurt, but the person's concerned about it. Like, think, could this be a cancer tumor? And if the answer is yes, say, well, I'm pretty sure it's this, but I guess it could be that. Well, then that sets the direction of your evaluation, which means you need to do more testing, whether it's see them back in 2 weeks to see if it's changed size, or do an MRI scan, or have one of your partners see it. Let's see. I looked like I knew what I was doing earlier. Oh, there we go. Okay.
Went the wrong way.
Okay, so this sounds just so straightforward. I was going to ask you guys, but I got a little behind putting my slides together, so I don't have them memorized in my brain. It's just intuitive, okay? If something is a cancer, it's going to grow. So things that aren't cancer and are big and are bumps, they usually change size. Like, oh yeah, but when I do this, it's not as big. Or, yeah, one day it was really big, and then I hit it with a book, and it's smaller. I mean, seriously, that's not uncommon, actually. But if it's something that has consistently gotten bigger, okay, you got to figure out what it is. Like cysts and things like those, they come and go and come and go. But if it's something that, yeah, seems like it came a year ago, and I usually ask them on dates, like, well, how about around Christmas? What do you think? Well, it's definitely bigger than it was at Christmas. Okay, you got to figure out what it is. And so be vigilant, particularly with children, because they don't fake anything. They just want to get out of the doctor's office and go play. And so things to be aware of is, when the pain doesn't fit the history. So you have, this is a true story, 18-year-old lacrosse player, D1 scholarship, high school senior, gets cross-checked, and his shoulder starts to hurt. Then his shoulder swells up. Then he goes into the emergency department, and they diagnose him with like a contusion or something. Then he goes home. Then he comes back 3 days later. Too much pain. Then they give him pain medicine. So he had 6 visits to the ED. And what he had, and so it didn't make sense, right? Okay, his shoulder's that big, it's bruised, he has intractable pain, he comes in holding his arm like this. Okay, that doesn't make sense for a normal person to be cross-checked and not be able to use their arm, right? So maybe he has a bleeding disorder that you don't know about and has a huge hematoma. But in this case, he had a sarcoma of his humerus, which fractured when he was cross-checked, and he ended up having a 4/4 amputation, which is taking everything from his ribs out, arm, scapula, everything, and then 6 months later he died. So that didn't fit, okay? So things like are listed there. There's not significant trauma. In that case, there was trauma. The location does not fit trauma. Sorry. They're trying to... No, you don't want to talk to him. Probably does. So some of the things that are really important I listed up there. Pain that lasts longer than it should. Okay? Pain at night. Pain that doesn't go away. It's all the time. Pain that increases with time and is unrelated to activity. So when I said before, I can just talk to them. So the bone cancers hurt. I mean, I'm not saying, oh, I'm great. I'm just saying, if you think about it, like when I meet a 13-year-old, I can tell pretty much just by talking to them if they have an osteosarcoma. And that's because of their pain. It never goes away. It increases over time, wakes them up at night, and it's not related to activity. Okay, to prove it otherwise, that child has cancer. And you have to spend time with them, though, and ask them questions. You can't just run in and blow it off. And so here's some things to think about on the history, because there are some things that are counterintuitive. If something's growing or greater than 4 centimeters, you should think of cancer first. Okay? Is it going to be cancer? Probably not, but you need to think of it first. As I said earlier, malignant tumors. So I'm talking about a tumor maybe this big in somebody's thigh. Will not hurt generally. And you'd be surprised. A lot of big people around, they got big thighs. They can hide these huge tumors in them. And the typical scenario, I took one out 2 weeks ago, is they were having trouble getting their pants on because they're too tight on one side. And lo and behold, they have this big, huge cancer tumor. But it's painless. Typically, the soft tissue tumors that hurt the most, typically not always, are benign. They're usually benign vascular tumors. They're fairly common. And they get engorged with blood, and the blood kind of gets trapped there, they expand, and they become painful. But the points are greater than 4 centimeters, it's not on here, but under the fascia. So you got skin, fat, fascia, muscle, okay? Under that fascia, if there's a mass there, you got to find out what it is. That's just like a basic rule. Basic rule number 2. If it's more than 4 centimeters and it's above the fascia, so it's in the fat usually, then you have to be concerned. You have to at least find out what it is. It's usually not a sarcoma. What are sarcomas? Basically, they arise. They're just like carcinomas are cancers of glands. Sarcomas are cancers of the musculoskeletal system. So they occur in things of the musculoskeletal system. You guys know more about the embryology than I do, but if you go back, it's like muscle, fat, synovium, nerves, blood vessels, cartilage, and then bone. The bone sarcomas arise in bone. Yeah. So here's just to re-emphasize how things can be mysterious. One of the most commonly misinterpreted findings on MRI scan is the interpretation that the patient has a hematoma. Okay? Here's an example of, so let's say this is one of you guys, okay? And you have this mass. Why would you have a hematoma? Yeah, trauma would be one. If you have a bleeding disorder like hemophilia, if you're anticoagulated for some reason, you had a PE and you're on Coumadin or something, or you don't have platelets for some medical reason. But in the absence of an explanation that's clear, you have to work up a hematoma, because a normal person doesn't just get a big, huge hematoma in their thigh. So that's a hematoma, actually is one, and this is a sarcoma. And just to show you, the radiologist cannot necessarily differentiate between the two.
Sorry, what's the UPS?
That's a diagnosis of sarcoma, like undifferentiated pleomorphic sarcoma. Because it's a good question, because the treatment of the sarcomas, there's a bunch of names for the soft tissue sarcomas, but the treatments are basically based on the grade, independent of angiosarcoma, synovial sarcoma, liposarcoma. It depends on the grading of them. So this would be that would be a high grade cancer. Here's a X-ray that's not that obviously bad, huh? Well, it is a bad X-ray, okay? Because why are you taking the X-ray, you think? What is you trying to see in an X-ray? What tissue are you trying to see? Bone. That's a trick question. Bone, right? So this is actually a bad X-ray of the bones, because there's not that much definition. And it's not uncommon that a poor X-ray is taken. So if you're in your office and you're suspecting, there's something in this kid's bone, and you get an X-ray that's a bad X-ray of a bone, then what do? Right. It's like getting a blood draw that's drawn incorrectly. So this child has an osteosarcoma right here. You can tell if you really squint or something, that's normal bone, and then this is more radiodense. But the point is, if you're looking for something on X-ray, be sure you get a good one. And then that's the MRI scan, which shows you where the tumor is. It's crossing the growth plate. So just to tell you, like from the surgery side, which is what I do, which is really fun, is so you would take this tibia out, like from here to here. Then you take the surface of the femur out, and then you'd put in a custom-made knee replacement with a donated bone from somebody else. So it's called a alloprosthetic, or APC, where you take out that tibia, which is really fun surgery, and then you have this huge hole, and then you take someone else's tibia, donated, you cut it, and then you do a joint replacement inside of it, and then you put that whole thing inside of the tibia and up into the femur. So then you do a muscle flap to cover the wound, but that's really technically very rewarding surgery to do. I'm showing this because one of the things that on scans that's really important is there a soft tissue mass on a bone scan? On an MRI scan of a bone, if something comes out of the bone, that's bad. Okay? It's usually a malignancy. So you can see this is arising in the proximal humerus, and the signal intensity is the same as here as out here, and so this is an osteosarcoma. In this case, this has spread inside the humerus. So what you would do in that case, which is again, it's very cool surgery. You would take that entire humerus out. through the elbow and the shoulder, and then you put in a metal humerus that's in a couple of different pieces. You do an elbow replacement on them, and then you reattach it up to the rotator cuff and stuff up in the. Here's another example: a tumor coming out of the bone. That's an osteosarcoma. You know, again, this is a big one. This is an osteosarcoma. What would you do here is you just take the femur out and then put in a replacement for that. Like this, for example. So this is, you know, the femur's taken out. You cut it with a saw right about here. And then these little notches here are different pieces. This little notching here. They come in different sizes, and then there's a bunch of pieces in here you can't see because they're radiolucent. But so that's an example. That would be called a hinged knee because all the ligaments are gone. So you got to put a hinge in actually, and then you just replace the bone with what we would call omega prosthesis. So I think I don't want to. Oh yeah, this is a good. See, I like this is another good one. So this is a 3-year-old. So a 3-year-old doesn't know what pain is. Okay, I don't know how many of you have children, but they don't understand stuff. Okay, so what do you think this child's going to be doing? Why is mom or dad going to bring this child in? Say it again? Yeah, limp, exactly. Okay, children should not limp. Okay, and so in a child who's limping, you have to figure out why they're limping. So this child does limping because they have this big Ewing sarcoma in their femur, and I don't think we have the x-rays, but what you would do here, there's 2 options on what to do here. One is, you know, you could take out this whole femur here, put in someone else's femur, and then put a big long plate on it. That's a bit of a problem because the child's got this, you know, that's the growth plate, and she's only 3. The other option you could do is you could take that whole femur out, and then you could put in a prosthesis that is expandable, that over time you can lengthen it through like a magnet. And then the third option is, it sounds a little goofy, but if you think it through tonight when you're trying to get to sleep, you'll understand it. You take that femur out to here, and then you would take the leg and move it up there. Okay, so you take the leg, this is the leg, this is the thigh, you move the leg up to the hip, turn it around 180 degrees, and then attach the top of the femur to the tibia. It's called a rotation plasty. And then the ankle, instead of moving, you know, like it's supposed to move, it moves the opposite, so it moves in the plane of the knee. So that's just an example of how cool our surgeries are. Okay. I think that's all I'm going to say. Are there any questions or comments about stuff? All right, thank you.
Thank you. Thank you.